As a nurse currently working in a cardiac intensive care unit, I chose the topic of preventing shivering during therapeutic hypothermia in post-cardiac arrest patients for my problem synthesis. The Institute of Medicine reported that there is an average of 60,000 cardiac arrests each year, about 40,000 of those occurring outside of hospital and 200,000 occurring in hospital. Of those cardiac arrests occurring outside of hospital, there is only about a 6% survival rate. The survival rate is higher for cardiac arrest inside a hospital, which is about 24% survival rate. The survival of cardiac arrest to discharge is only about 10.8%, with 9% of those individuals having a good neurological function. Once ROSC is achieved, the patient's neurofunction is checked and they are evaluated for therapeutic hypothermia, also known as targeted temperature management. Therapeutic hypothermia is indicated in patients with a poor neurostatus, meaning there is a loss of neuroreflexes such as pupillary response, cough, gag, purposeful movement, etc. Studies show hypothermia interrupts the ischemic pathways in the brain and can improve neurofunction by 49 to 55%. Targeted temperature management, or TTM, is performed with various specialized cooling equipment. At my facility, we currently use Arctic Sun, but we have been trialing Zoll's intravascular cooling. Arctic Sun provides surface cooling via the application of external pads as seen in the photos to the left. Water passes through the pads and adjusts patient temperature via the water temperature. Zoll's intravascular cooling, on the other hand, uses an endovascular approach to cooling. A central venous catheter, similar to a triple lumen, is inserted into the body and water is passed through the small balloons on the catheter. As blood passes past the catheter, the core temperature is adjusted. The therapy occurs in 3 phases, the first being induction, where the patient is rapidly cooled to a targeted temperature, usually 33 or 36 degrees Celsius. The second phase is the maintenance phase, where the patient remains at their targeted temperature for about 24 hours. The final phase, rewarming, is where the patient is slowly warmed to 37 degrees Celsius, usually by 0.25 degrees Celsius per hour. Once the patient is rewarmed, the goal is to wean sedation and obtain a thorough neuroassessment. On average, it takes about 3 days for the patient to quote-unquote wake up. However, it can be longer due to the type and amount of medications they receive during therapy. A major issue with the cooling process is shivering, which is common as your body temperature approaches 35 to 36 degrees Celsius. Shivering is detrimental to the therapy as it counteracts by increasing the patient's metabolic rate by 2 to 5 times greater than normal, meaning there is an increase in energy expenditure, oxygen consumption, and carbon dioxide production, as well as an increase in heart rate, blood pressure, respiratory rate, and intracranial pressure. All of these factors generate heat, thus hindering the cooling process. To assess for shivering, the Bedside Shivering Assessment Scale was created in 2011 by Jahada et al. and has been validated and utilized in many studies since. The scale is used to distinguish the severity of the patient shivering on a scale of 0 to 4, as you can see on the table shown. There are generally pharmacological recommendations associated with each score, which I will discuss more in detail later on. The interventions to reduce shivering are listed here, the first being non-pharmacological, where counterwarming measures are utilized. By warming the skin, the body is not triggered to shiver even though the core temperature is cold. This can be done by a bear hugger or by applying blankets, socks, gloves, or a hat to the patient. Other popular medications are listed, including non-sedating and sedating drugs, as well as paralytics. Paralytics are routinely utilized by some facilities at the initiation of therapy to prevent shivering from ever occurring, but research is paving the way for alternative medications to be used to prevent shivering and eliminate the harmful side effects of paralytics. With continuous paralytics, the patient must be deeply sedated. Research shows that with deeper sedation there are worse outcomes, as these medications can linger with an impaired metabolism. They can also lead to hypotension and a reduced cardiac output. Heavy sedation can delay wakening, impair neurological assessment, and result in inappropriate withdrawal of care. It also suppresses seizure activity, which is a marker of brain injury. Research suggests surface cooling may cause more shivering than endovascular cooling due to the mechanism of cooling. Surface cooling requires the cold to pass through different layers, such as skin and muscle, in order for the core to reach target temperature. Because the body is cooled from the outside in, it is suggested that cooling time may be prolonged. Another concern is temperature control, where it can be easy for the machine to overshoot the desired temperature for the patient, thus making the patient's core temperature either too warm or too cold, and it taking longer to adjust the temperature. With endovascular cooling, it is argued that there is a reduced level of shivering because the cooling is not applied to the skin. It is also argued that cooling time is decreased because the therapy is applied directly to the core. The same principle dictates tighter temperature control because the temperature change does not have to pass through as many layers. The final comparison is mortality rate. A lot of research will have to be done in order to determine if one therapy has a higher survival rate or incidence of a better neurological outcome than the other therapy. There are many nursing implications of this topic, especially to RNs working with the post-cardiac arrest patient population. The first being that TTM protocols are nurse-driven. At my facility, we are very influential in how the therapy is performed. We are currently looking at switching our protocols, which has prompted my interest in this topic. We are looking at moving from continuous paralytics toward alternative pharmacology, which is the nurse-driven change. This therapy is also heavy in nursing judgment. The early recognition and prevention of shivering, as well as seizure activity, is crucial to the success of the therapy and patient outcomes. Being proactive in ensuring the patient is receiving the correct intervention is important to patient safety, as well as to providing high-quality care. Responsible for eliminating secondary injury due to shivering and seizing by maintaining stable hemodynamics, ventilation, electrolyte balance, and maintaining an appropriate level of sedation. To ensure a thorough literature search, I utilized 3 different databases in order to find relevant studies. The 3 that I utilized were CINAHL, Cochrane Library, and Medline. The first study I found is called Variation in Sedation and Neuromuscular Blockade Regimens on Outcome After Cardiac Arrest. The aim of this study was to evaluate sedation and shivering management practices of different facilities post-cardiac arrest. The study found that facilities using as-needed neuromuscular blocking agents had an increased odds of a good outcome compared to facilities using escalating doses of sedation and avoiding neuromuscular blocking. Their evidence supported that sedatives are metabolized slower secondary to hypothermic state, and that high doses of sedation take longer and are harder to metabolize post-therapy. The study was published in 2018, making it relevant within current literature. The study was conducted retrospectively using data on 4,267 post-cardiac arrest patients from 20 different facilities. This large of a sample size provides more accurate and valid findings. Researchers also adjusted the odds ratio for a number of different factors that influence the outcome of cardiac arrest, such as patient age, time till ROSC, location of arrest, whether or not it was witnessed, bystander CPR, early defibrillation, initial rhythm, past medical history, and the size and location of the hospital the patient presented to. One limitation of the study is that the type of TTM, whether it was surface cooling or endovascular cooling, was not included in the data analysis. Although this is a level 3 study, it is strong in the aspect of utilizing retrospective data. The second study I found is continuous versus intermittent neuromuscular blockade in patients during targeted temperature management after resuscitation from cardiac arrest. The aim of this study was to identify the effect of sedation and paralysis on neurological outcomes after TTM post-cardiac arrest. The study concluded that continuous neuromuscular blockade decreased shivering, amount of sedation, and ICU stay compared to the intermittent neuromuscular blockade use. This study is strong due to the level 1 evidence of a randomized, double-blind, double-dummy experimental research study. In this way, bias has been severely decreased. The experiment included 63 participants with an even sample size, 32 patients in the continuous neuromuscular blockade group, and 31 in the bolus neuromuscular blockade group. While it seems like 63 is an adequate sample size to me, I would have liked to see a confidence interval used in order to validate findings. The study also failed to mention if bispectral, or BIS, monitoring and/or train of 4 monitoring was used during TTM. Train of 4 monitoring is required to ensure the patient is adequately paralyzed, and BIS is for monitoring levels of sedation. BIS monitoring must be used for all patients receiving paralytics in order to ensure the patient is adequately sedated. If both groups were receiving BIS monitoring, in theory they would have been equally sedated, thus possibly impairing the findings of the bolus neuromuscular blockade group receiving more sedation. The third study I have incorporated is the prevention of shivering during therapeutic temperature modulation, the Columbia Anti-Shiver Protocol. The aim of this study was to determine the effectiveness of a developed stepwise protocol that emphasizes the use of the least sedating regimen to achieve adequate shiver control. The study found that a significant proportion of patients can be effectively treated for shivering without oversedation and paralysis. This is the Columbia Anti-Shiver Scale that researchers developed and then tested in the study. As you can see, many of the medications I listed earlier in this presentation are utilized in this stepwise protocol, increasing from shiver prophylaxis at step 0 all the way to neuromuscular blockade in step 4. Oftentimes, this protocol is matched with the bedside shivering assessment scale, and medications are suggested based on the level of shivering as seen here. Although the study was published outside of the 5-year golden standard, I felt as though it was still relevant to this discussion, as it is oftentimes still used today in TTM. Another fault of this study is that it was conducted in a neuro-ICU on neuro patients that either underwent induced hypothermia or induced normothermia to prevent hyperthermia. This is a level 2 study where researchers implemented a new protocol. There were 213 patients involved, creating an adequate sample size to support their conclusion. I would also have liked to see the study include benzodiazepines, which are common medications used in TTM, to see if that would impact outcomes. Despite the study not directly involving post-cardiac arrest patients, I believe the data on shivering has been validated and can be applied to the post-cardiac arrest patient population. Assessment of anti-shivering medication requirements during therapeutic normothermia, effective cooling methods, is the 4th study I've utilized. The aim of this study was to compare the degree of shivering as well as the amount of anti-shivering medications administered in surface cooling compared to endovascular cooling. The study conducted that there was no significant change in the degree or intensity of shivering between the cooling mechanisms. They also found that patients undergoing endovascular cooling required more non-sedating medications, while patients undergoing surface cooling required more sedating medications. This study was published in 2016, and while the data is relevant, there may be more research being conducted on this subject. While the study incorporated 68 participants, 43 of them belonged in the surface cooling group and 23 were in the endovascular cooling group. This makes me wonder if the results would have been different if the sample sizes had been even. Another downfall of this study is that the patients were not post-cardiac arrest, and they were maintained in normothermia. I do, however, believe the study has implication toward my targeted patient population in the aspect that the same cooling therapies, shiver scale, and medications were used. Researchers suggest in the conclusion that optimizing non-sedating medications such as acetaminophen, buspirone, and magnesium infusions may decrease the requirement for sedatives to control shivering in both groups. This makes me wonder if the bedside shivering assessment scale was utilized correctly, and if researchers thought that if the scale was used more accurately, if it would have decreased the amount of sedation given. The final study I included was the comparison of 2 sedation regimens during targeted temperature management after cardiac arrest. The purpose of this study was to compare 2 sedation regimens, propofol, rafentanil, and metalzamfetanol, on time to waking. The study found that patients who received the P2 regimen woke up faster than those who received the P1. P2 also had decreased incidence of delayed wakening, which was considered to be wakening greater than 48 hours, earlier extubation, and required less sedatives. There was no change in neurological outcome post-therapy. This Level 2 study was published in 2018, providing strong, up-to-date literature. The study had an adequate sample size of 460 patients, however, the sample size was uneven, with 326 patients in the P1 group and only 134 patients in the P2 group. Again, due to the uneven sample size, I wonder if the results would have been different had they been even. A missing piece in this experiment was whether or not a shiver assessment scale was used, or if neuromuscular blocking agents were administered any time throughout the TTM therapy. I believe the use of either of these entities would change the sedation requirement, thus possibly hindering the results of the study. The researchers were, however, successful in collecting and analyzing pertinent data to support and fulfill the aim of their study.